So we talked about the visual inspection. Ideally, we'd have her in a gown, but you're looking at the clavicle, AC joint, and this is where you'd see your sulcus on the distal tip of the acromion. C-spine exam. I'm going to push on her C-spine. Does that cause any pain? No. Can you put your chin down to your chest and go all the way back in extension? Good. And then just look over each shoulder for me. Awesome. So that looks pretty good. And then Sperling's test, and that's spelled S-P-U-R-L-I-N-G-S, or apostrophe S. You're just going to push down the top of her head. And if that reproduces the pain into the hand or the fingers, it's probably a cervical problem. You can also turn the head towards the side that hurts, and that sometimes enhances it if you push down. So that's a quick C-spine exam. You've kind of ruled out some of the cervical spine pathology.
So if it's just shoulder, people won't say ow when you do the Sperlings?
Should.
Right? Okay.
Yeah. Should be comfortable to put just a few pounds of pressure on their top of their head. Palpation, so we're going to palpate the SC joint here, work our way down the clavicle. And I always say, if you look at a patient that fell off their bike and they've got a big step off on their clavicle, don't move them around, don't push real hard. If you can see the fracture, and a lot of times you can with the clavicle, it's going to hurt them. It's pointless to do a bunch of testing. Get them an X-ray and see if it's fractured. Same thing with the AC joint. They'll have a huge step off right here. It'll come out, and I'll show pictures of it here pretty soon, but they'll have a big step off. And I'm going to palpate. Be careful palpating in the bicipital groove. It's usually tender even if the patient doesn't have pathology. It's just a tender area. When you do that, if you take their humerus, so they're just sort of in neutral, and you externally rotate, now you're going to feel that lesser tuberosity of the humerus, and this would be the greater. So you're basically rotating that so you can feel it, and that's where the subscapularis attaches. So you're going to feel pain there with subscap. Biceps tendon is pretty much always tender, and so make sure you're palpating that. Most people would be tender there with rotator cuff pain. Sometimes they're just tender back on the muscles, and I always try to find the spine of the scapula, and then right above that is the supraspinatus, and below that's your teres minor infraspinatus. So that's kind of your main anatomy that you need to palpate. You always want to do a quick elbow exam. Are you tender down here? And give it a good squeeze. You know, some people fall and they've got a olecranon fracture. They've got a rotator cuff tear. You don't want to have them leave the clinic because their cuff was torn. They've got a fracture somewhere, so push around. And I always say, do a quick intrinsic. Hold your hands open real wide for me. Yep, don't let me squeeze your fingers. Good. Can you pull your wrist back and back down? Wrist extension sort of rules out if they have a proximal humerus fracture and they have radial nerve palsy. So you're checking their wrist extension. So I always do that on the shoulders too.
Okay.
All right. So let's have you stand up. Let's see if we can still see. I'm going to move your chair.
Okay.
So you stand kind of right there, maybe. Okay. Good. And so for range of motion, I'm just going to have her bring both arms up as high as you can in the front. So we'll do flexion. So all the way up as high as you can. Good. Come down. And then we're going to have your arms at your side. Just raise them both up like this as high as you can. Good. Arms at your sides. Rotate out as far as you can. Come back in. Let's turn you around backwards. How far can you reach your thumb up your back? So reach up your back as high as you can. Good. Do the other arm. So you're a thrower.
Mm-hmm.
So Kim's lost a little motion. You guys can see that, right? And that's just from throwing. You know, if she was a softball player, you could go ahead and turn around. She's going to have a little bit of rotator cuff problems. She probably stiffened up a little bit over the years, so that's normal. And now, there's your range of motion. So now we're going to go right into manual motion testing. So I just have her reach their arms up in front. Hold your arms up. Don't let me push them down. Good. Hold them like this. Don't let me push you down. You try to stop me. Good. Hold your arms at your side. Don't let me push your hands together. Good. Don't let me pull them apart. And so that's pretty much your manual motion testing. That's all I do for the shoulder, unless I'm focusing in on one specific thing. So we're going to do some provocative maneuvers. Here's the next slide. You guys will see this here in a minute. But so for the AC joint, let's sit you back down. Yeah, there we go. All right, so AC joint, we're going to do horizontal adduction test. So what that is, this is the AC joint. I'm going to bring her arm across her body, and I just kind of push like that. With an AC sprain, that really causes pain. We also use that test a lot to determine when people can go back to play. You know, when that pain goes away, they're probably ready to play. Piano key sign, so all that is, if you're looking at the clavicle and it comes down, this is the AC joint. You can just let your arm rest. And their clavicle, the distal tip of the clavicle is sticking up. When you put your thumb on that and you push with the other hand, it will bounce up and down like yours might be moving a little bit. It basically looks like this, and it'll bounce up and down like a piano key with like a grade 3 AC separation. That's a great test. I always bring people into the room when I see that to show them, because
And they can tolerate it?
they don't have much pain with that usually.
Oh,
Yeah, it's pretty weird. When you have a grade 3 tear, you've torn your acromioclavicular ligaments, you've torn your coracoclavicular ligaments, so they're all sort of torn up. And when everything's just kind of ruptured, in my experience, there's less pain. The grade 1s and 2s really hurt. I don't know why that is.
what type of injury would that, like, when you have that type of,
So that would be caused, it's your high school quarterback, and the guy kind of picks him up and, you know, slams him down, and he gets a blow like this.
okay,
So clavicle fractures usually happen when you get crushed. So I tackle you, I land on top of you, and this gets crushed.
okay,
Guy in his 45-year-old guy wrecks his bike out in the road. Always a clavicle fracture. That force when they hit the ground just crushes it.
okay,
AC separation is a lot more in athletes, wrestlers, because they pick each other up and they slam each other down, and it's just that real hard blow that drives the humerus down, and the acromion goes pushed down, and the clavicle stays up. So that's how it happens. Okay, so these next tests are really important. So we're talking about impingement now. The 2 tests that you need to know for impingement, and the most important one is the Hawkins-Kennedy. So you're at 90 degrees of flexion. You just put your hand on the elbow here. And I'm just pushing down on her wrist. And you see if that causes pain. You can also lift up on the elbow as you're doing it, and it kind of pinches that bursa up against the acromion.
so lift up, push down.
Yep.
And if I have pain, you're gonna think impingement?
Impingement.
Okay.
Yeah, and it will hurt with rotator cuff tear too. So, and all the orthopedic surgeons do it out here. I don't know. I get more positives than abduction. It's not really documented like that, but if you lift them up, even just that with impingement sometimes hurts because you're pushing the bursa up against the acromion. Now I'm rotating like the same thing. And I bet you if I do this on your right, you being a thrower, you're probably not gonna like it.
Okay.
You just let your arm go.
Okay,
Does that hurt at all?
yeah, a little bit.
Doesn't feel great, does it?
No.
So even for me, when people do that to me, it just doesn't feel good. Okay, so now the other one is near impingement test. These are all named after surgeons back in the olden days. I'm just kind of holding her scapula with my right hand, and I'm pressing her into flexion. I don't like that test as well, but I usually do it. I always do Hawkins if I take impingement. So rotator cuff, I usually do these standing up. Let's have you stand again. We'll just move the chair back and kind of have you stand there. So empty can test is probably the best one to isolate the supraspinatus. So I just have them, when you're doing empty can, you don't want to be in flexion and you don't want to be in abduction. You're right in between the two. And you're going to rotate as far as you can internally, and that's the position. And I usually do them both at the same time. So I'm going to have her like this. You hold up and don't let me push.
Okay.
Probably, you can go ahead and relax. We'll cause pain with impingement. With rotator cuff tears, they're not even going to be able to hold their arm up like that. As soon as you let go, they're just going to drop, which is the next test, the drop arm test. The drop arm test is basically, you can let that one go. So they're standing there and they're all kinds of pain. You say, let me have your arm. You try to let it relax. I'm just going to lift her arm up. Now you try to hold your arm up.
Okay.
And you just let go. And I'll do it to me, Kim, and I'll show you what the patients do. So she's going to lift me up, and then I'll go ahead and let go. They're going to go. They always shrug up because they're trying to. People with cuff tears, they kind of do this little thing. So sometimes they don't even have a lot of pain. They've been torn for a long time. They just can't lift their arm up. So
Okay.
that's a drop arm. We're going to go right into external rotation. So arms at your side, push against my hand.
The camera's on.
Yeah, there we go. Thank you. Push real hard. Good. So now you're isolating teres minor and infraspinatus. And now push against my hands real hard, and this would be subscapularis. The other test for subscap, let's turn you around backwards. And move your foot here. Let's put your hand behind your back. Good. So this is going to isolate the subscap. This is called the lift-off sign. So open your hand real wide and push against my hand really hard. She's got really good strength. Sometimes you just ask them to lift their hand off their back, lift it off. You can't do that with a subscap tear. They just can't get that movement started. So that's good. Awesome. So that's your rotator cuff test. All right. So we're going to move on to the labrum. So O'Brien's test, it's kind of a variation of Speed's test, which is what we used to use for biceps tendonitis. But O'Brien, Stephen O'Brien, he's out in New York. He's a real famous orthopedic surgeon with athletes and throwers. Flexion, fully externally rotated, and you hold the arm up, hold it real hard. Good. That isolates the biceps tendon and takes the rotator cuff out, because this is going to be rotator cuff and this is going to be biceps. If they have a slat tear, which is the long head of the biceps coming up on the labrum and it peels off, that usually causes pain. So that's why we do that one.
Is that when they get the Popeyes?
So if they tear their long head, they will get the Popeye arm. So there's two Popeye arms, that's a good question.
Okay.
If she tears her long head of her biceps off of the labrum, you know, there's always tension on muscles, so if you tear them, they're gonna retract. It's gonna retract distally, you're gonna have the Popeye down here. If she tears her distal biceps off of the radius, the Popeye goes up here.
Okay.
That right there is surgical every time, distal biceps tears.
Oh.
That's the guy that's lifting the refrigerator out of the back of the truck and he feels his arm pop and he's got all that bruising and swelling in his forearm.
Uh-huh.
Distal bicep
So
tear.
distal always surgery, proximal,
Hardly ever.
how do they?
If it's a younger patient and they're worried about the cosmetics, they'll do what's called a tenodesis. They'll take that tendon and they'll tack it down either in the bicipital groove, they'll do it on, sometimes they do a subpectoralis, tenodesis. They're basically attaching it somewhere else that's not on the labrum. And sometimes they do that intentionally just to take the pressure off the labrum.
Okay.
It's called a tenotomy is when they just cut it. Like in
Okay.
an 80-year-old guy, he doesn't care about Popeye arm, he can't even see it. They just cut it in surgery.
So it doesn't affect any functional,
No, because you still have your short head intact. Short head
Oh.
attaches with the coracoid, so you still have most of
okay,
your elbow flexion power.
okay. And you don't usually tear your short head, you always tear your
Hardly
long head
ever.
normally, okay.
Yeah, the short heads, you'd have, yeah.
Okay.
I don't think I've ever seen it,
Okay,
yeah. So what I was gonna show you real quick, we're gonna do more of this later with the elbow, but Kimberly's got a nice, really good bicep, and if they tear their distal bicep, you take your finger here, you just kind of pull on it like that.
mhm,
That goes away when it's torn. It's really
Oh,
easy to,
you
I mean,
can't-
it feels like a bowstring in there. I can move it around and it's just gone.
yeah,
You don't feel anything.
okay,
That's a great way to diagnose that.
okay.
Compression rotation test. Let's,
Real quick though, if this is surgical, still probably sling and follow up though, it's nothing that needs transfer right away or?
no, but you don't wanna wait too long because with tendon tears that are surgical, the longer you wait, the more it retracts. Because
Okay.
as they're moving it and contracting that bicep, it's just kind of migrating up.
So call, get follow-up within 2 to 3 days, hopefully?
I would, hopefully, yeah.
Okay.
And make sure you tell the surgeon, I think they've got a distal biceps tear, and then they're gonna get them in quicker usually.
Okay. And another question that people always seem to wonder is, there's no testing, like, sometimes people say, oh, we do an ultrasound to verify.
Well,
We
you-
wouldn't do that.
We don't have it,
Right.
but if we did, musculoskeletal ultrasound is great for diagnosing tendon injuries. You
Will
would
they do that, will the surgeon do that before?
Probably.
Okay, to verify.
If they had it, yeah.
Okay,
They would probably do an MRI. If they have
Oh, okay.
musculoskeletal ultrasound, MSK ultrasound, they would do
okay,
it.
okay,
Yeah. I did all kinds of ultrasound when I was an ortho. It's really cool to see it,
Okay.
especially superficial tendons show up great.
okay.
Let's go into continue with the labrum. So we did the O'Brien's test. That's kind of a quick and easy one. The compression rotation test, I don't know how sturdy these tables are. We have a video of the phone. I'll test it on you.
Okay.
Oh, we're good. Yeah, we're good. So just lay on your back here. Let's see if we can. Yeah, it's perfect. All right. So compression rotation test, if you're thinking labrum, all you're doing is I'm grabbing her forearm, let your arm just kind of go. And I've got a hold of her forearm, I have my palm against the elbow and I'm kind of holding her scapula here. Just let me have it. And I'm driving the humerus into the glenoid and then I'm rotating. Let's see, we should do your right arm, you probably have a tear. Lots of throwers have labral tears and don't do anything about it. So this one feels perfect. But you'll feel like a click or a clunk as you're pushing in and
But it's a label.
if it's a labral tear. Yeah, that's a great test. I do it all the time and I get lots of clicks and clunks. And the patient will go, that's what it feels like when it hurts. Biceps load, you bring them into full abduction and you're gonna have her flex her elbow against your resistance. So you're gonna try to bend your arm up towards your body.
Okay,
Yeah, real hard. And that right there really pulls that long head off of the superior labrum. So that'll cause pain.
okay.
Let me see what we got next before I get you up. Can't remember. All right, I'll stand you up. I just run through more here. The shoulder tests are kind of lengthy and involved. The rest of them aren't this long, but. So we talked about O'Brien's test for the labrum. Speed's test is kind of the same thing. So speeds, you kind of have them push up against, flex up as far as you can. Just the shoulders, you're gonna go up like that. So that's Speed's test. If you're thinking biceps tendonitis or sometimes with biceps instability, subluxing, that'll cause pain. The other test for biceps tendon is Jurgensen's test. So I'm gonna resist her in flexion. And as she's pulling up, flex. As she's doing that, I'm gonna externally rotate. You can also put your thumb on the biceps, so pull up. and sometimes you'll feel it click over that greater tuberosity as it subluxes. So some people tear that retinaculum that keeps that biceps tendon, and they'll say, well, when I'm throwing, it feels like it's just popping, and they'll kind of point to here. So that's biceps instability. Jurgensen's test. Glenohumeral instability, let's have you lay, well, you know what, we'll just do it seated, just because the rest of them are seated. I like to do apprehension, so we're moving on to glenohumeral instability, that patient that you think may be dislocated. Apprehension test is probably the best one to do. I like to do it laying down, because when you lay down, it puts the scapula, it locks it against the table, it gives you some help. Seated, sometimes they're leaning back because they're guarding, they don't like this. So if they've dislocated anterior, you just bring them 90 degrees of abduction, and you just passively externally rotate, and they will stop you because they're gonna feel it coming out. That's the apprehension part. That's a great test.
And when one does dislocate their shoulder, it's usually anterior?
Almost always anterior.
Almost always, okay.
Yeah. Sometimes they, when they come into your office, when you look at their shoulder, let's see if she has a little sag. She's got a little bit. This is called inferior distraction. So I'm just basically pulling down on her humerus, and this is the acromion. You'll see like a little dent right here. And that's just testing for inferior instability. Sometimes after they've dislocated, they're just sitting in the chair, and you see that big dent just from them sitting there because their capsule's all stretched out. So, and that leads right into load and shift test, which is a really good test for glenohumeral instability. You basically hold their clavicle, and you put your thumb on the spine of the scapula, and you give that a good squeeze. Now you're stable. You grab the humerus, and you're gonna push the humerus into the glenoid real hard, and then you're gonna shift it anterior and posterior. That's the load, and this is the shift. So this is and this test is important to do to the other side, because you're basically testing for any differences. Everybody's gonna move a little bit, but if they dislocated, you load and you shift, they're gonna move a lot. So you're grading how much they move. So that's a great shoulder instability test. We talked about sulcus sign, that's just inferior distraction, and you're looking for the sulcus. That's the next one. Push-pull test, let's lay you down for that one. Yeah, awesome. Push-pull test is for posterior instability. So what you're doing is you're holding her wrist here. The push part, you have your hand on the proximal humerus, that's push, and the pull part is pulling on the wrist. So I'm putting a posterior load on her. You probably feel that.
Yeah, and that's gonna tell what?
Posterior instability.
Okay.
So push-pull.
Meaning that,
They've dislocated posterior.
oh,
Yeah.
okay.
And then, so relocation test, I don't recommend you do this one, but it's, if you're not quite sure if they're popping out, basically relocation test is like doing apprehension. So I'm externally rotating her. She's like, oh, I don't like that. Now I come over here, can you see this, Yvonne? As I'm pushing this into external, I take my hand and I apply an external posterior force to her humerus, and then she says, oh, it feels better.
Oh.
And there's actually a version of this test where you keep going like this, and then you let go, and it'll sublux. I don't recommend you do that, but if you just do this to where they say stop, 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 and then you do this and they feel better, they have anterior.
Anterior dislocation.
Yeah, probably.
Okay.
Shoulder instability. Okay, two more, and we're done with the shoulder. Let's have you stand up. So whenever you have that patient who has numbness and tingling in their fingers, maybe their neck's not really sore, and you're thinking, what is this? Nothing's really making sense. Think thoracic outlet syndrome, and don't forget, it's commonly missed. And thoracic outlet is basically the nerves coming out of your neck, the brachial plexus. They get pinched by either there's the first cervical rib can do it, the scalenus muscle can do it. There's all these different causes. But the tests for that, and it doesn't take long to do them. The first one I always do is have the patient face away from me. Yep, good. And all you're doing is you're pulling. Let me just pull this up.
Sure.
You're palpating her radial pulses. See if you can see that. And you've got her shoulder in extension. So as I bring these back, you will feel a difference in the pulse on the side it's bothered. If you turn her head towards that side, so look to your right, if it's a right shoulder, a lot of times the pulse just goes away when they turn their head. That's
Really?
yeah.
Wow.
And that's a cool test. If you ever get one, bring everybody in and show them, because you're pretty cool that you caught it.
Okay.
Yeah, let's have you turn this way now. And then Ruse test is basically just 90 degrees of abduction, and you're just gonna open and close your hands. And you just do that for about a minute or two. And just by holding that position, so about like this,
Mhm.
they'll start getting the numbness and tingling in their hand as they do that.
And that's also thoracic outlet
Thoracic
syndrome.
outlet. ROOS, RUSE test.
So they do this for 2 minutes, and when they get numbness and tingling, that could be it, and
And
then.
they do the ADSONs.
What was this one again?
ADSONs, ADSON apostrophe S,
Okay,
ADSONs.
okay.
All righty. There's our shoulder.